Good morning, everyone, and thank you to the Australian Commission on Safety and Quality in Healthcare for inviting me to join you for the launch of the Delirium Clinical Care Standards and to contribute the consumer perspective about the impact of delirium on a person and why this clinical care standard is so important. Every medical condition we know is about a person with an individual history, friends and family, and a personal story. The person in the centre of this story is my husband Michael, a healthy, fit, intelligent man who had been a fitness trainer in the British Air Force before becoming a British-trained remedial gymnast in rehabilitation for people with a disability. He was an elite sportsman, had a love of life, and also for his family. However, around the age of 59, 60, Michael began to experience changes, upmost being that he became increasingly disengaged. This was so unlike him. Disengaged with us and with life. Something was wrong. We sought help. After 3 misdiagnoses and 6 years, Michael was finally diagnosed with a younger onset dementia. He was then just 66 years old. 8 years into the progression of his dementia, Michael had a temporary 6-month stay in residential aged care. During this period, he had several admissions to acute hospital care. The first admission followed a collapse, thought to be a stroke by the residential aged care staff. On admission to the hospital emergency department, he was found to be an acute renal failure with severe urinary retention. The next night, he became extremely agitated and was trying to climb over the bed rails and couldn't be controlled. No one contacted us. Someone judged to give him 5 times his normal dose of risperidone to quieten him down. He was rendered unconscious for 5 days. At the end of a subsequent 5-week stay in hospital, he was discharged, but had more noticeable changes in his cognitive capacities. He was now incontinent and required an indwelling catheter. A month later, following another collapse in residential care, he was thought by the staff to be in kidney failure. They recommended to us palliative care. He was very quiet, unresponsive to us, and withdrawn, despite him being fine with us just the previous evening prior to the fall. We asked for him to be taken straight to the emergency department of the local teaching hospital. On arrival, his admission to ED was delayed by nearly an hour. Michael was still very quiet, not communicating, unfocused, withdrawn. Attention was prioritised by the ED staff for new arrivals who were in a more agitated state. So we waited. When he was finally admitted, he was found to have severe urinary retention as a result of a blocked catheter tube. During the subsequent 6-week admission, it was decided to undertake surgery to alleviate the necessity for his indwelling catheter, which he kept trying to remove and causing internal damage. Following the surgery, I asked to join him in the post-operative unit, anticipating he would be frightened in the unfamiliar environment and with aspects of the post-surgical care, but I was not allowed in to be with him. The next morning, on visiting, I found him tied by his wrists and ankles to the bed rails because of his extreme agitation and distress. The nurse, sitting at the end of his bed writing notes, picked up a roll of bandage, threw it at him and said, "Here, play with this." The fear on his face was palpable. His final admission from residential care a month later followed an apparent fall, which left him unable to mobilise. He was again very quiet, withdrawn, unresponsive. He was admitted to ED on our request and found to have 2 fractured ribs and an injured swollen knee. In his immobile, uncommunicative and very unresponsive state, the attending doctor described him as similar to someone with locked-in syndrome. After 6 weeks in the acute aged care unit, he was for discharge, but he had lost his mobility, had a compromised swallow reflex, further changes in cognition, and was considered to be palliative. We brought Michael home to care for him ourselves, and where he died 6 months later. Each of these acute hospital admissions for Michael as a person with dementia was distressing, sometimes frightening for him, causing an exacerbation of his symptoms and the acceleration of his condition. No one spoke with us about it at the time or explained Michael's sudden changes in behaviour, but it's likely he was experiencing delirium. As I now know, people with dementia are at increased risk of developing delirium during a hospital admission. With the introduction of this Delirium Clinical Care Standard, a person like Michael will now be immediately identified when presenting at hospital as being at risk of delirium. He would be promptly assessed in consultation with his family and carer, who would be asked about any recent changes in his behaviour or thinking. They, the people who know him. His diagnosis would be discussed with the patient and family. He would be offered interventions to either prevent delirium or treat the causes of his delirium. Care would be based on reducing his risk of falls or further injuries. Non-pharmacological drug strategies would be the prioritised approach to relieving his distress, including involving his family in this care. And at discharge, the family would be involved in the development of an individualised care plan and provided with information about delirium for ongoing care after leaving hospital. This Delirium Clinical Care Standard will support consumers to know what health care should be offered for delirium, and they can expect to make informed decisions in partnership with their clinicians. This is their right, we know, as Australian healthcare consumers. The Commission is to be congratulated for identifying delirium as a priority for the development of a national clinical care standard and supporting this development with the establishment of a Delirium Clinical Care Standard Working Group, expertly chaired by Associate Professor Gideon Kaplan, who was wonderful, and co-chaired by Dr. Judy McCraw, together with professional experts and also consumers. This working group was fortunate in being supported in its work as well by the Commission's hard-working staff. They were amazing. As part of the Commission's Caring for Cognitive Impairment campaign, this Delirium Clinical Standard will support safe, high quality and appropriate care for people with or at risk of delirium. So congratulations and thank you to everyone involved, and not least of all to my husband, Michael, a courageous man who taught us so much about living with the impact of dementia and, importantly, about the special care needs of people with delirium. So thank you very much for listening.
Thank you, Joan. Thank you so much. It makes such a difference to have the patient and the carer perspective. We really, really appreciate you coming forward and telling your story. What sort of difference, you touched on it, but what sort of difference would it have made, do you think, if these standards were in place when you were dealing with this and Michael was dealing with this?
I think undoubtedly we would have been involved from the beginning with the clinical care staff. We would have been very much involved in contributing to them understanding any particular changes that were different, because we knew Michael very, very well, and we knew on each of his presentations in the hospital that I've described that he was different. There was something very, very wrong. So that working together in partnership with clinicians would have been a significant difference and will be a welcome change with these standards.
And also, just to touch on your role as a carer, what difference would it make to you as a carer to have these standards in place?
It would have been an immense relief to understand what was actually happening to Michael, to understand the seriousness of delirium and what it could bring to him and the changes it would make. And it would also help us be involved much more helpfully, much more effectively with the clinical care team in his care throughout the whole course of his admission. I felt we would have been much more effective, much more understanding. So again, the standards will be terrific in supporting this.
Thank you so much, Joan. Please thank Joan again for her contribution.